Welcome, everybody. We are delighted that you have joined us. This is the Committee on the Review of Dietary Reference Intakes for Energy. And I am going to, I welcome the sponsors who have joined us, as well as the US and Canadian DRI Steering Committee chairs or representatives who will be presenting to us. And I would like to first ask the sponsors to state their names and affiliation. And I think you can see on the agenda that we have an order of sponsors. And I'd like for you to please follow that order if you don't mind, in introducing yourselves and showing us who you are on the screen. And so thank you, Cindy. You're the first one. So I'm going to have you go ahead and get started and do those introductions.
Hey. Hi, I'm Cindy Davis. I'm a National Program Leader for Human Nutrition at USDA ARS.
Thank you, Cindy.
Hello, I'm Donna Johnson Bailey. I'm a Senior Nutrition Advisor with the Food and Nutrition Service at USDA.
Chris?
Yeah, hi, I'm Chris Lynch. I'm the Acting Director of the Office of Nutrition Research at NIH.
Essie?
Yes, hi, this is Essie. I'm so sorry, I'm having issue with my camera. I am at FDA, CFSAN, Office of Nutrition and Food Labeling.
Amanda?
Hi there, I'm Amanda McFarlane, and I'm a research scientist and the chair of the Canada-US Joint DRI Working Group.
Janet?
Hi, good afternoon. I'm Janet DeJesus, Nutrition Advisor at the Office of Disease Prevention and Health Promotion.
Judy?
Judy Simon, National Nutritionist Administration for Community Living.
Jenna? Jenna's not on yet, but that would be Jenna Seymour from CDC. Okay, we'll wait for her to come. Hopefully she'll join us real soon. And then I would like to ask the committee members to introduce themselves. And so let me start with myself. I'm Anna Maria Ciegariz. I am the Dean of the School of Public Health and Health Sciences at UMass Amherst, and I'm the chair of the committee. And may I ask Sue Roberts to introduce herself next?
Good afternoon. I'm Susan Roberts. I'm the team leader for the Energy Metabolism Laboratory at the USDA Human Nutrition Research Center on Aging at Tufts University, professor of nutrition at Tufts, professor of psychiatry and staff member in pediatrics at Tufts Medical School.
Thank you. Beth Yetley?
Beth Yetley, I'm retired from NIH, nutrition scientist from NIH.
Thank you, Beth. Heidi Silver?
Hi, I'm a professor of medicine at the Vanderbilt University School of Medicine and a health scientist in the Department of Veterans Affairs.
Thank you. Nancy Butte?
I'm a retired professor of pediatrics from Baylor College of Medicine, Children's Nutrition Research Center.
Ethan Balk?
I'm an associate professor at the Brown School of Public Health with expertise and experience in systematic review, having done a lot of work for the Agency for Healthcare Research and Quality.
Thank you, Ethan. Amy Luke?
Hi, I'm Amy Luke. I'm professor and chair of public health sciences at Loyola University Chicago.
Thank you. Lanika Blackman-Carr?
Hi, I'm Lanika Blackman-Carr, and I'm an assistant professor of community and public health nutrition in the Department of Nutritional Sciences at the University of Connecticut.
Reagan Bailey?
Hi, I'm a professor of nutrition science at Purdue University.
Susan Barr?
Hello, I'm Susan Barr, Professor Emeritus of Nutrition at the University of British Columbia in Vancouver, Canada.
Janet Tews.
Hi, I'm a professor of biostatistics and data science at Wake Forest School of Medicine.
Thank you. And I think I have all of our committee members have just introduced themselves. And so now I'm going to turn the floor over to our representatives from the US and the Canadian DRI steering committees, Carl Friedel and Maya Villeneuve. If you'd like to take over.
Thanks very much. So I think I'm listed first. We can go in any order here. I can figure out how to start my charts. Well, maybe you could push the charts from your end. Alice, is that possible? Thank you very much. That'll just be a lot simpler than me trying to do it. Can you put that on presentation mode? I think if you just go to the little, there we go. Thank you very much. So I'm the co-chair of this committee, subcommittee under the Interagency Committee on Human Nutrition Research on the US side. And so we've got sort of or tri-chairs with our Canadian friends. We all work together very well, and it's a great group. So I'm the co-chair with Cindy Davis, who is from USDA, and I happen to represent the Department of Defense. I'm Chief Physiologist of the Army. And we all have the same sort of end goals and interests in mind as we have worked to set up the contracts for this and think about what we want and what our individual agencies need out of this, and how this will tie to some of the other panels, in fact, that'll follow it. So you're the very first in a series of panels, especially related to macronutrients that will follow. If I could have the next slide, please. This is a great chart that others on the team put together that really highlights sort of how you fit in with the other uses of DRIs. So up in the corner there, of course, is NASEM, and your panels develop these recommendations that have a huge impact. There's this cascade effect, of course, and some of these even sort of come out and have sort of force of law in impacting nutrition across the country, and of course, influencing Canada as well. And you can hear about that after this presentation. So, for example, the DRIs feed into the dietary guidance. It's a big impact there. But it also feeds into even clinical guidance for disease management. So each of the federal agencies gets different things out of the DRIs, and they're used in different ways. I'll show you even more specifically a couple of uses for the USDA on the next slide. But on this one, even the Department of Defense, for example, then bases all of their rations, the content of the rations, and the total amount in the ration from the energy guidance of this panel. It used to be we had military RDAs. That was sort of silly because soldiers are people, and it turns out they're a lot more like people than, we're not creating mutant soldiers. They're normal people, and they can follow the same guidance everybody else has. So it has a huge impact even for feeding in the DoD. But each agency gets something out of these DRIs, and they're foundational to the rest of the food guidance and the nutrition guidance. There's even a part that you guys will identify in terms of where you just don't have enough evidence to provide guidance. And that's especially important to NIH. It will help Chris Lynch and others to identify, or you're going to help identify the research gaps and give you some future areas for funding. So it even has that impact. Next slide, please. This is specifically a piece from the USDA Food and Nutrition Service, 3 major programs that hinge on that dietary reference intake guidance. The SNAP program, This relates to benefit allotments for households across the country, and the valuation of these foods and so on are based on current dietary guidance. The child nutrition programs, there are at least three main ones listed there, also depend on the recommendations that are age appropriate for the provisions. And the WIC program that many of you should be familiar with would be impacted in terms of the food packages that are provided to eligible individuals based on, again, the dietary reference intakes. And it really does have force of law. Your recommendations are authoritative statements that then get that permeate through all of these other regulations and even laws that affect feeding throughout the country. So these three programs here represent 97% of all USDA expenditure for domestic food and nutrition assistance. That's a big program. They touch probably 1 in 4 Americans across the country. So yours is an important task. It has a huge impact, and I guess that's the point of these slides. So my next and last slide, if we can go to that, just has some of the questions that had come up several times, and I'm not sure that we quite captured those for you in writing. And it's part of what perhaps we could even discuss today. So, the task is to update the energy requirements. But what's new and different from the last time this was done? One thing that keeps coming up for us is what is healthy? And we now seem to have healthy fat Americans. The BMI recommendation of standard 25 has shifted, and there's a lower mortality between BMI 25 and 27.5. And those aren't just more Americans with more fat-free mass. There's more fat, but there seems to be a tolerable fat, maybe because of better medicine or something that allows them to do this. It's a consideration for you guys as you think about even this calculation. Is it time to actually try to estimate fat-free mass as part of it, or can we still go with body weight? Do we have to be more precise? And skinny fat Americans, of course, are this digital generation that we're starting to see much more of, even in Army recruits that are metabolically obese, but normal weight. They look like they're absolutely normal. You put them on the DEXA and there's no fat-free mass, and it's a lot more fat. Should the different energy requirements be recommended across different categories of weight? Ultimately, we want energy balance. It should be straightforward, right? We say, here are the requirements if you want to be in energy balance, but a grossly obese person shouldn't be trying to stay in energy balance necessarily. So it's something that this committee might want to consider how these new guidelines might be tabled and presented. There's a lot of new data, of course, since the last one, all based on doubly labeled water. We're well aware of the IAEA database, and wanted to make sure there were representatives, in fact, on the panel that have some direct connections to that. I think the panel can bring in consultants and even add to the panel if that's necessary to get more expertise in any of those areas. One question is, can that kind of data also be expanded into, and not that data specifically, but can we use some of the abundant wrist-worn accelerometry data, especially if it's calibrated to doubly labeled water studies? Would that provide any additional insights for your recommendations? It's something to consider. And then we had things that might push into that sort of future research recommendations if there isn't enough known at this point. But one question that came up repeatedly in our discussions was, what do we know about the source of macronutrients and how that might affect energy requirements? We all recognize nowadays that a calorie isn't a calorie isn't a calorie. And if it's calories from alcohol, that's a little bit different than calories from protein. and how we're going to metabolize those and how much of that is going to go to supporting energy requirements or get stored as fat. So I think that area might be one that the committee could really take on. Seems to be a lot of literature in that area. We didn't do any scoping reviews for this because we felt that it's a fairly constrained research area and you guys are the experts and would know. And we didn't need to provide you with additional information that was just extra baggage that might not be helpful. We didn't know how to, in other words, we didn't know how to focus on, any kind of meta-analysis to help the committee. And then the last one is definitely in this research category, but are there new considerations and things like what we understand about microbiome and how that affects our energy balance? So I think there's a lot of exciting stuff here. It's going to be, I think, a fun committee. I wish I could be a fly on the wall, but at least if you guys have a workshop or two, we will love to participate and hear your thoughts as things go along. So that's everything I think I have to say. And other members of the panel, of course, are going to weigh in the open discussion here. And, they've got lots of ideas. I'll leave it at that.
Thank you, Carl. Will Maya be doing a presentation?
Yes, I will. Good afternoon. My name is Maya Villeneuve. I'm the Associate Director in the Bureau of Nutritional Sciences at Health Canada, and I'm also the co-chair of the Canadian DRI Steering Committee. So let me share my screen. Here we go. Let's put it from the beginning. Can you see my screen right now?
Yes.
Sounds good. All right. Just going to move backward. There we go. All right. So just to provide an overview of the presentation I'm going to be doing today, I want to quickly highlight some sociodemographic characteristics of the Canadian population, since that may have some bearing on the work that the committee is going to be undertaking. As well, mention some of the expectation of the work of the committee. I won't go through the use that we do of the DRI. I think that was quite well covered by the presentation made by Carl. So just to provide some context, the slides, the information on the slides comes from the 2016 census that took place in Canada. There was also a census in 2021, but the data will not be available until February 2022. But it should be available in time to be provided for the committee to conduct the risk assessment portion of the task. So updated information can be provided in about a month or so. Canada, as you can see, is a pretty big country, but most of our population live close to the southern border. It's concentrated mostly in urban center, spread across Canada, and the population of Canada is a little bit over 35 million as of 2016. And as many of you probably know, there's significant outdoor temperature gradients between the southern and the northern latitude in Canada, particularly in the winter months. So another aspect of Canada is the visible minorities of population in this country. Just to provide you a definition that is used in Canada, it's visible minority is considered a person other than Aboriginal people, who are non-Caucasian in race or non-white in skin color. So again, according to the 2016 census, there was more than 7.5 million individuals that identify themselves as belonging to the visible minority population. So that's about 1/5 of Canada's population, so it's quite significant. Of this number, about 3 in 10 were born in Canada. South Asians, Chinese, and Blacks were the 3 largest visible minority group. each with population exceeding 1 million. So just to give you an idea, South Asian population was about a quarter of the visible minority. Chinese population represented about 20%, and the Black population actually surpassed the 1 million mark for the first time in 2016, and it's the largest in terms of numbers. One thing that's also interesting with the Canadian Black population that's distinct from the US, the top birth countries of Black newcomers is Haiti, Nigeria, Jamaica, Cameroon, and the Democratic Republic of the Congo. So just to give you an idea of where the newcomers are mostly coming from, as we mentioned, Asian countries, Philippines, India, China, Iran, Pakistan, Syria, and South Korea. And previously, the second group used to be of newcomers was coming from Europe. And it's the first time that Africa actually ranks second. And most of the immigrants were coming from Nigeria, Algeria, Egypt, Morocco, and Cameroon. So the high proportion of visible minority and their ethnic makeup is highlighted because we are interested in the applicability of the RI values to the various large subpopulations in Canada. We also recognize that some standards that directly relate to energy, such as the BMI range, considered to be healthy, may not be completely appropriate for all subpopulation, since the current standards were derived predominantly from studies in Caucasian population. So for example, the cutoff for overweight may actually need to be lowered in Asian population. So another important aspect in Canada is the government of Canada continues to be committed to a renewed nation-to-nation relationship with the Indigenous people. So First Nations, Métis, and Inuit are not considered visible minorities. It is also of note that in the far northern latitudes, the large majority of the population is Indigenous. In addition, the food choices of Indigenous people are influenced by a number of unique factors, including the role of the community, issues related to geographic isolation, urban versus a rural environment, and a diet traditionally based on foods procured directly from land and water. Now, one thing you can see on this slide that's quite interesting is the Indigenous population in Canada is quite younger than the average, than our average. Our average is at 41 years of age, and the Indigenous population is at 32 years of age. And it's also a growing segment of our population. So population also is another aspect that's important. It represents one of the major changes associated with Canada's age and sex structure. It continued to shape Canada's society and economy. So the demographic of aging process is currently accelerating as individuals born between 1946 and 1965. So that's the largest baby boomer cohort are reaching advanced ages. And we estimate that approximately 17% of the population is currently aged 65 years and over. Another important aspect is the prevalence of overweight and obesity. It is something definitely that is relevant when considering the RIs for energy. The data that we're showing here, they were taken from measured height and weight collected in the 2015 Canadian Community Health Survey. And taken together, overweight and obese adults make about 60% of the Canadian population. And in children, this is about 30% of the population. Now, one thing that's interesting is the rates of overweight and obesity seems to be holding steady over the last decade or so. The rates of overweight and obesity based on measured height and weight taken from 2004 were very similar to those rates from 2015. Now, I just want to quickly describe what is some of our expectation for the work of the study committee. Body size and physical activity are key components that affect energy requirement. However, we do not expect definition of healthy weight or physical activity recommendation to be outcome of this study. In Canada, we use the standards for healthy weights in adults, children, and the appropriate gestational weight gain. They are aligned with the World Health Organization recommendations. We are definitely interested in any statements you may have on the applicability of your work to various ethnic subpopulation, but we're not looking for you to actually redefine the standard on healthy weights. The Canadian Physical Activity Guidelines, they are developed by the Canadian Society for Exercise Physiology, and they're integrated into a 24-hour movement guidelines that also take into account advice on sedentary time and sleep. And we do recognize that the EER needs to consider activity levels, and the existing 4 levels of physical activity coefficients have been sufficient so far for our needs. We also expect that the risk characterizations conducted will consider factors that may be important to Canada, such as those that we highlighted earlier in the presentation. Of importance would be any statement that can be made on the applicability of the new EERs to the various population of interest. Now, of course, transparency documentations of key decision is something that's quite important for us as well. And we expect that a comprehensive review of the science be conducted and factors related to energy expenditure that may not be sufficient body of evidence to be considered as of yet, still be documented so that there is an indication of the state of the science on these. Just to provide a few examples of these, what these could be, consideration of brown fat, fidgeting, or long-term energy restriction, and also any identification of knowledge gap or areas where further research is required would also be quite useful. So thank you very much.
Thank you, Maya. Appreciate that. I just want to now remind folks that this is an open discussion with our study sponsors. It's open and recorded. We also have a lot of individuals who are listening in and have been asked to attend, but we will not be opening up questions for the floor. And at the end of our discussion with the sponsors, the committee will be going into closed session. And I ask that those of you who are not committee members to please leave at that time. So let me open it up and see whether or not our sponsors have any comments on the study task that they would like to share with us first before we get into any questions from the committee members. Please raise your hand and I'll be happy to call on you. Yes, Dr. Lynch.
Yeah, so, well, it's not a question, but again, going back to what we were just talking about is like hoped for things. The, there has been, NIH's interest as Carl mentioned, is in identifying research gaps and opportunities. And we heard from the Canadian side about, some of the things that have been discovered, since the last DRIs were performed, such as, the components of energy expenditure, non-exercise activity, thermogenesis, and, brown fat. Also, well, maybe it wasn't discovered. Well, it's probably, we were certainly aware of it, but maybe didn't have the words for it at that time, the microbiome. We know from animal studies, for example, that, farmers have this trick they use to get animals to market faster by giving them antibiotics. It increases their, the utilization of their energy, or the, their ability to convert energy into mass. So, that's something that maybe could be reflected upon. We had this recent science paper about energy expenditure across the lifespan that some of the members are authors on. And, one of the things that, is quite obvious from that was the large inter-individual variability in energy expenditure, which between individuals, and so the which maybe when I was younger or in graduate school, that wasn't really a consideration. We had this idea that that you could probably calculate somebody's energy expenditure, or needs quite accurately. And what is the underlying basis for that, which must be, the ability to turn on or turn off various efficiencies or inefficiencies. And so since the last, DRIs were completed, we've had a lot more information about things like uncoupling proteins. We mentioned brown fat, but there's also other, we've made discoveries about thyroid hormone targets, for example, SERCA1 in muscle, and other ways to alter efficiency of biological activity. For example, fast skeletal muscle troponin has almost 128 splice isoforms, and some of these splice isoforms allow troponin to allow muscle contraction much more efficiently, and these splice isoforms change across the evolutionary spectrum from insects to mammals in obesity, or if you just even take an animal and put weights on it. So I think there's a lot of science that has emerged, but and so where and in the last DRI report, there was a lot of reflection and consideration about this, and it would be nice if that continues into this next DRI report. And I also fully agree with our Canadian colleagues about, we're very interested here in these special energy requirements for special populations, and what additional data might be needed for that. And then finally, we're going to be using a lot of doubly labeled water for this, but to what extent can we use room calorimetry data, or deploy that in addition to doubly labeled water? If you have some thoughts about that. Thank you.
Thank you, Dr. Lynch. Any of the other sponsors who would like to say something? No. Okay. Well, I know our committee had some questions to sort of engage our sponsors into a dialogue. And so I would ask that our committee members raise their hand and propose the questions that we have been sort of mentioning during our previous conversation. Anybody want to start? Nancy, please go.
Under our statement of task, it includes defining energy requirements for individuals with comorbidities. Specifically was mentioned obesity, diabetes, and others. In our planning committee, which I know many of you were present at, we had landed on the idea that many of the chronic diseases are really based on obesity. So my question for you all is if that premise would be acceptable, if our committee really addressed the needs of the normal weight population and the overweight and obese population, would that sufficiently address your concerns about individuals with comorbidities?
Well, I mean, obviously you won't be able to dive into something where there's no data. But, if there's some data within these databases on patients with type 2 diabetes or other disorders that maybe have been where the, confounding to obesity or something has been removed, I think that should be, could be reported out. But it may be very well that there's that there's no there for that data.
I think there will be individual small studies identified. So certainly it could be addressed in a text. I just suspect, but I haven't looked for many years. I suspect there's not enough data, doubly labeled water specifically, to develop equations. And so, like I said, I think it can be mentioned what small studies do exist, but not to develop prediction equations.
Yeah, I would say that that would be sufficient, because again, you want to have it, you want to go where the evidence is, and if the evidence isn't there and it's not strong enough to base actual EERs on specific populations, then that's a knowledge gap that can be recognized.
And this sounds like a very tidy way to produce the recommendations. We don't want complexity. It just confuses the public and everybody else. So I think bundling it a little bit that way, or reducing it to obesity and normal weight, is a very sensible way to move this ahead.
I also agree.
Another question from our committee? Yes, Ethan.
Hi, when we were discussing the scope, one of the things we talked about was that there are questions related to the association between energy intake and chronic health outcomes, endpoints, and other health outcomes. And well, I was wondering if there are a priority list of outcomes. I know there are some that are listed: obesity, cardiovascular disease, type 2 diabetes, some types of cancer. But any further thought that would help us potentially kind of not so much narrow the scope as keep the scope, within a framework we can kind of work with? Are there specific outcomes that are of particular priority?
I think we usually default to type 2 diabetes, as sort of maybe the earliest form that you see with obesity-related disease. As a committee, I don't think we've identified any specific other priorities, like some kind of cancers, or there's all sorts of stuff out there in the literature, of course, and we're relying on you guys to suggest to us what might be important in addition to something like type 2 diabetes. I think that's as far as we got. Is that right, Amanda?
Yeah, and I think Cindy wanted to mention something, but I do think that it would be primarily those major chronic diseases that are associated with energy intake, which are going to be, diabetes and cardiovascular disease. But Cindy, I think you had something to say.
Well, I was also going to say there's a lot of evidence that the World Cancer Research Fund and the American Institute of Cancer Research have found linking obesity to a lot of cancers. So I think that there is a large body of evidence there. But the question is, are the recommendations going to be any different than avoiding obesity, and then the link that the obesity has with the chronic diseases, rather than just looking at energy intake and the chronic diseases if it's all just being mediated via obesity?
Ethan, did you have a follow-up to that, or is your hand just still up from leftover?
Oh, sorry, no.
Okay. All right, Sue? Sue, you're muted.
To press on the question of the chronic diseases a bit more, are we talking about energy requirements to prevent chronic diseases, to live with chronic diseases, or to treat chronic diseases? And I mean, I think based on Carl's wonderful slides, we're not talking about treatment. So are we talking about, if we wanted to see if there's any data out there, enough data to create prediction equations for, say, type 2 diabetes? Would this be for energy requirements to prevent or energy requirements to live with the condition without treating it? I'm just trying to find out what our mandate is.
The DRIs are designed mostly as primary prevention. So we're looking at, it's not looking at treatment. And so it would be looking at prevention or perhaps maintenance in a healthy, if the energy requirements are different in those states and you have the evidence to support a different EER for those states, then that would be perhaps something you would do. But yeah, it's not secondary prevention or treatment.
Thank you.
I think that's exactly right. I was startled at the International Alzheimer's meeting several years ago when the opening keynoter started out by saying that if we just had better weight management, we could reduce perhaps by 50% the incidence of Alzheimer's, because in fact it's a metabolic disease. So, I mean, it just has such wide sweeping, consequences. I think it's prevention that we'd be most focused on.
I mean, that makes it Nancy's question very relevant, since obesity is like a feeder disease for Alzheimer's, type 2 diabetes, cardiovascular disease. I mean, whether there's any data prospectively on people who develop type 2 diabetes versus not, independent of body weight, would be a tall order probably. But there's a ton of data on obesity as a risk factor, for example.
Janet?
Yeah, thank you. I wanted to ask a specific question along the lines of the two questions that have just been asked, which is, now that we have this chronic disease risk reduction DRI, were the sponsors anticipating we would develop or explore developing a CDRR specifically for energy?
That's not necessarily what we were thinking about. Really, the energy, we're looking at defining energy requirements.
So just the EER, basically.
Ethan?
Just a continued follow-up of the earlier conversation, and just for perspective, I'm coming at this as a systematic reviewer with some nutrition experience, but not the energy expert. I'm trying to wrap my brain around the difference between energy intake as a predictor and obesity as a predictor. I mean, yes, there are clearly probably thousands of studies associating obesity with outcomes, diabetes, probably in particular, cardiovascular disease. I'm trying to wrap my brain around whether we should, in preference, restrict it to energy intake, and I'm not sure what exactly that means, I'll be honest. So any thoughts kind of guiding us whether we should try to make that distinction, and if so, how that distinction would be meaningful from your perspective?
I think we've talked in circles around those questions in our committee. And it's sort of, the energy to prevent obesity, the obesity to prevent, some of the chronic disease, energy and the chronic disease relationship. And I guess we're hoping that your committee will talk in circles and straighten it all out for all of us. I mean, I don't think we have a really good, clear answer for you on that.
Carl, thank you for your honesty there. And do we get a reward if we do? Just teasing. Beth, do you have something to add to this conversation, or was it a new question?
New question. Do you want to continue this?
Unless one of the other sponsors had something else to add. No. Okay, please do.
One of the frustrations when you work in public policy, health nutrition policy, is having to rely so often on self-reported intakes, which we know are biased, particularly with relevance to energy. And I was wondering if the committees, the DRI committees, are interested in having some kind of evaluation of if and how and when you could use EERs to evaluate the quality, perhaps the direction and magnitude of bias in self-reported intakes.
Beth, you've of course picked a good one. This is a tough one. You know, I think especially after the fact, once you've got the EERs and then we're looking, you know, at the risk assessment in the population, maybe that's where that relevance would be about when it would be applicable and maybe when it's not. I don't know, Chris, did you have a response to that? That's a challenge.
Well, I just no, we're not asking you to try and correct you know, dietary you know, self-reported dietary intakes with doubly labeled water. Is that what you're asking?
No, not really. What I'm asking is if you had to use self-reported intake data for whatever project you're working on, and you want some estimate, maybe qualitative, but some estimate of the underreporting bias and how it varies by different groups, would you see it appropriate to have some discussion or guidance on that particular question in the DRI report, guidance in the DRI report?
I think you have enough, frankly, I think you have enough work to do already without adding that. That sounds like a whole, you know, a whole bunch of NIH projects to sort that out. I mean, you'd have to have studies where they had very high quality, you know, dietary intake data and the doubly labeled water. Not that there aren't some of those, but you know, I just think that that's beyond your task. We're wondering what the energy requirements should be. And then one of the other reason I had my hand raised, because the other thing, you know, we've been focusing here on obesity, but you know, we want to think also about developmental outcomes, you know, stunting and you know, macrosomia and you know, birth weight and things like that.
I like Beth's premise there. That could, you know, help with sort of clinical guidance coming out of the specific area of the DRIs for energy. You know, there's lots of new data that we didn't have before where they've used doubly labeled water to kind of test the inaccuracies of self-report. But to come up with some kind of scheme like with formula to be able to use that in practice might be a useful adjunct. Depends, as you say, the committee's got a lot to do here, but I wouldn't discard that.
Yeah, I definitely think it's related. Obviously, once you have the EERs, you need to apply them, and this is part of the application aspect of it. And so if you have the ability and time to address it, even in terms of, you know, where the biases are, would be helpful.
Thank you. Susan?
Actually, I see Janet has just raised her hand, and probably she's going, are you going to talk about the risk assessment, Janet?
I was just going to mention the other Janet. Sorry. I thought you were calling on me.
Go ahead, Janet.
Yeah, I was just going to say, I mean, I think it's a really interesting idea that Beth brought up, but I would just be concerned that the scope is, I mean, this is a lot of work to do, reviewing all the evidence to possibly update an EER. So I'm just not sure that it will fit into the timeline for this activity. So, I mean, if there happened to be a lot of extra time, you know, as Chris mentioned, you know, there's probably a lot of research, et cetera, but I would like to focus first on the task that we put in the statement of work before looking at the bias issue. That's just my opinion. Thank you.
I was just going to say, I do think it has some impact for the risk assessment piece, because we don't have a national doubly labeled water database, right? I mean, or nationally representative doubly labeled water database. We have self-report data, which we know is different than doubly labeled water. So I do think there's some implications potentially for the development of the task related to measurement error and systematic bias that we know is related to overweight and obesity. So I just wanted to mention that.
So I see Heidi had her hand up, and then I'll go to Susan and then Nancy Butte.
Thank you. I just want to bring up a concern and question whether any of the sponsors had raised this concern, which we certainly recognize obesity is an epidemic globally, not just nationally, and is the largest percentage, of the population is overweight and obese. But there still exists a significant amount of malnutrition related to involuntary weight loss, particularly in older adult populations. And so I don't want us to forget, that among the BMI categories, yes, we have overweight, obesity, and the classes of obesity. But in addition to normal weight, we also have underweight, and, malnutrition is highly unrecognized in clinical settings. We know that 30 to 50% of hospitalized older adults have malnutrition from involuntary weight loss. And it would be, frankly, disheartening from my perspective as having been a clinical practitioner and a scientist if we don't recognize the existence of that and take that into consideration too, especially when we're talking about primary prevention of risk, that, risk of the consequences of malnutrition, especially in the older adult population, is very significant with the degree of falls and fractures and the, terrible decline that occurs from fractures straight to mortality, lack of physical function, physical dependence, and mortality.
Chris, did you want to respond to that before I go to Susan and Nancy?
Well, just Heidi, this is a first part of several DRIs that are going to be done, including protein, where I think this issue of aging and frailty, we hope to maybe address in there. I can concur with you about that, but as we saw in the Poncer paper, there were changes in energy requirements that were not necessarily intuitive, in that Poncer science paper. But I think another thing we haven't talked about is if you're going to get into that area, is the in terms of the risk of over nutrition of energy, is this idea of the double burden of obesity, the because we do have also in hospitalized adults, there's a lot of people who are overweight and obese, and a lot of them have micronutrient malnutrition that impacts their clinical outcomes and comorbidities for surgery and for whatever else they're in the hospital or clinical setting for. So that could be a topic that maybe could be mentioned.
Yeah, I mean, and also the rates of sarcopenic obesity, are right. did a study, it hasn't been published yet, but the proportion of individuals with sarcopenic obesity ranges from 20-year-olds to, 100-year-olds. It's highly prevalent.
But do you think that's energy or protein?
You're muted, Heidi.
And that was so brilliant what I just said, and you missed it. No. I think it's a combination of both. When you're talking about sarcopenic obesity, you're talking about energy and protein and the interaction between the two. Yeah.
All right.
So Susan and then Nancy, and then I know we're going to go over time. So I think I want to end with Nancy and then allow our committee to sort of do next steps. So Susan.
Thanks. One of the questions that had come up in our earlier discussions was related to the risk assessment question and whether you'd be expecting us to report on that relative to energy intake per se, or relative to BMI, body weight classification, metabolic risk factors. What were you thinking of in terms of the risk assessment issue?
I think it will be of interest if you have enough evidence to say have different EERs that would apply to different subpopulations. So maybe it differs by BMI status or things like that. Then I think the risk assessment would want to include some of those finer assessments, not just the generic population. I think it's going to depend on where your evidence leads and where the new values lead, and then the risk assessment should follow suit. Does that help?
So risk assessment based on reported energy intake?
Well, I think for the risk assessment, that may be all that we have. So it's going to be, I don't know if anyone else wants to jump in, but normally that's what it's based on.
Because then that gets back to the earlier discussion of the need to calibrate, because we know that energy intakes are, we'd have a huge prevalence of risk if we used reported energy intakes. So
I know it becomes a vicious cycle.
Tightening the circle rather than.
Yeah, no. And unfortunately, I think that's going to have to be left in your domain to decide. So again, if you have evidence that suggests that you have different values or different requirements depending on various characteristics, then ideally the risk assessment would reflect that. If it becomes an application issue because of bias in the data that you have for your risk assessment, then that might be something that you do want to address. But we don't want it to take over, I guess is what we're talking about, because we don't want it to direct you away from the main task, if that is helpful.
Does Judy or Chris have a response to this? Okay, so then I don't see Judy's face, so I don't know. Nancy, do you want to have the last word here?
Well, as our sponsors, I was wondering if you could maybe quickly summarize what you think are the current limitations or problems with the current EERs from your organization's point of view.
Well, one of the limitations is that it's missing all the new data that we have had since the last time these were reviewed. And I mean, there's a huge number of studies, and another sort of limitation is this, is this obesity epidemic, and the fact that if we wanted to, let's say, try and take some public policy actions to lower the calories on the food label, or recommend that people eat lower amounts of smaller amounts of energy, we wouldn't be able to do it because we must sort of, what you're doing is very important, because we must follow, the rest of us must follow these DRIs and really not deviate from them. Is that correct, Janet? Janet De Jesus.
Judy, I know you've had your hand up, so let me let you go ahead, please.
Oh, thank you very much. It's been fascinating discussion. We at the Administration for Community Living, we utilize the DRIs to basically set requirements for what meals must provide. And our observation and feedback that we've received from our thousands of organizations providing meals to older adults nationwide is that it's too much food. And so, really dovetailing with the concern that it might be leading to obesity. We've been hearing that it doesn't fit into their diabetes meal plans because, again, with the calories. So we're talking about health implications, food waste, which, as I'm learning more about food waste, even relates to climate change. And of course, the cost of that extra food. So it really, just reinforcing and what we're hearing so that we can share that with you. So thank you.
Thank you very much. I believe we are now over time, and I would like to ask everybody who is not a committee member to please sign off. We look forward to seeing you again at different opportunities for us to engage with you.